Welcome to this talk on head injuries. But before we start talking about head injuries, I want to talk about something very important. Patients with head injuries often have reduced levels of consciousness and therefore can't tell you if they have a pain in their neck or in their back. And it's very important that if a patient has got a reduced level of consciousness and a head injury, we assume that they have a spinal cord injury until proved otherwise. And particularly we're concerned about injuries to the cervical spinal column, the first 7 vertebrae, with the spinal cord running through. Now the spinal cord is a bit like this piece of paper. It's in between, it's going through the cervical vertebrae. And that's fine as long as the cervical vertebrae are intact. But what can sometimes happen if a patient's been traumatised, there can be a fracture to the cervical vertebrae. And that means that there is an instability. Now actually that doesn't matter too much as long as we maintain good alignment. But if someone comes along and moves the head and the body independently, then because the neck is now loose, this is completely useless now, isn't it? The spinal cord can be completely transected. So a fracture of the cervical vertebrae can be displaced, damaging the spinal cord. And of course the importance of this can't be overstated. That means if there's a complete transverse lesion of the spinal cord, the patient will never feel anything below the level of that lesion ever again. They will never be able to move anything below the level of that lesion ever again. That's why we have to be very careful to look after the cervical spinal cord. And we maintain alignment of the head and the neck by neck braces, blocks on the side of the head, and taping the head to the trolley or the transfer trolley or whatever the patient happens to be on to maintain stability. And we don't take them off until we've taken x-rays where we can see from C1 all the way down to C7 and T1 to make sure the cervical vertebrae are intact. Let's have a look at these in some more anatomical detail now. So here we see the occipital bone of the skull and the first cervical vertebrae. And in this model the nerves are in yellow, nervous tissue is in yellow. So the first cervical vertebrae is sometimes called the atlas and the second one the axis. But that's C1, that's C2, 3, 4, 5, 6, and then the 7th cervical vertebrae is this more prominent one here that you can feel when someone's head is bending forward from the back. So 1, 2, 3, 4, 5, 6, 7. And then we're on to the thoracic vertebrae after that. So that is the first thoracic vertebrae there. So that's T1, T2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. That means this must be the first lumbar vertebrae, which is L1, L2, L3, L4, and then down to L5. And we can see that there's nerve roots coming out between the vertebrae. 31 pairs of spinal nerves, of course, altogether. So this is the first cervical nerve root. C1, 2, 3, 4, 5, 6, 7 and 8. Now note that there are 7 cervical vertebrae but 8 cervical nerves because the first one is above. 1, 2, 3, 4, 5, 6, 7, 8. Then this means these are the thoracic nerves. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11 and 12. And then the lumbar ones 1, 2, 3, 4 and 5. But thinking about the cervical spinal cord, we can see the massive importance of this here, because if these vertebrae are broken and they can displace and tear the very delicate neuronal tissue in the spinal cord. And if the cervical cord is broken, the nerve impulses can't get down, carrying motor impulses, the sensory impulses can't get up, and the patient can't feel or move the entire body below that level, with of course devastating consequences. So please do look after your patients' spinal cords, particularly their cervical spinal cords.